is maybe a little bit of a different flavor of a talk. I do a lot of work in implementation and dissemination and safety around healthcare safety and quality practices. I'm going to talk a little bit about that. But I'm a human factors psychologist, and I trained at UCF, where Maddie is, and Dr. Earhart a long time ago. And a big focus there, and for me, has been on teams and the role teams play in bringing about safe care and high quality care. And that also means kind of learning and improvement and change, which is coupled all together with dissemination and implementation, right? If we want to implement something, we got to change it. We have to do something different. Turns out how teams function in an organization makes a big difference for our capacity to actually do those things. And that's the root of this. I'm going to talk about some implementation projects I've done and how teamwork plays a role in there. But one of my other areas is just measuring teams and how do you kind of assess how well a team is performing and the factors that influence how well they perform. So I'm going to talk about some things that are about measurement, but really have no immediate role for implementation. But I think the goal is to provide some kind of food for thought, right? Here's some ideas around new ways of thinking about how we can kind of conceptualize and assess teams and how they interact and how we might use that in some of our implementation studies. Some of it's ready for prime time and you can take and probably implement in some of your studies now. A lot of it isn't, but the field is moving really fast in some of these areas. And it almost certainly will be before our careers are done and probably before the next few kind of years are passed. So some acknowledgements. In a lot of the work I'm going to talk about here, some of the studies are funded by kind of those agencies, the VA, a few different NIH centers, and some of the NASA work that I'll talk about too. So the agenda, I'm going to just spend a little bit of time talking about teams and teaming and how that relates to implementation science. We'll talk about a couple of frameworks from each of those and how they kind of fit together. But then really, what are the opportunities in our implementation research studies to measure and assess teams, and why would we do that, and how could we go about doing that? So I'll spend a little bit of time on that. Then I'm going to talk about three kind of examples of unobtrusive measurement systems, or at least approaches, some more practical than others. The first one's going to be extremely practical. In fact, we've used it in an implementation study around enhanced recovery pathways and surgery. We'll talk about what we can do to better understand just patterns of work amongst our team members, and that really does impact the care that they deliver. Talk about that study, and then a few others that are becoming more practical and feasible, particularly around the communication. I'll talk about a couple of studies we did to understand communications between patients and providers that are related to patient-reported outcomes and other things. So we'll talk about some strategies that you could potentially use for that, and those are becoming the data to generate those measures become much more practical, right? We all have ambient sensing systems for recording and transcribing and summarizing our patient encounters now. We're launching one next week. Pretty much everyone, I think, is piloting them and trying them. So that means there's a lot more communication data available. And so does use of telehealth and televisits means that there's more opportunity to capture and use communication data. And the last one's probably the least immediately helpful, but it's using wearables and tracking for individuals and how you can capture aspects of their interaction and what that means for their stress levels and their perceptions of teamwork in a really busy kind of work environment, a pediatric intensive care unit. Yep. So some frameworks. There are many different frameworks of teams and what the components of teams are that you should consider. Like every, I think, discipline of inquiry, we have a version of a structure, process, outcome framework. This is kind of that turned on its side, but it is helpful for a lot of people. I think it captures some kind of foundational things that need to be there, more structural things about the organization, about the leadership systems that need to be in place, about the individual competence of the people participating in those teams, and how the organization has worked to kind of define roles and the whole team structure, essentially, and norms. Within that, the people have team competencies for what they do, think, and feel around valuing teamwork, around the trust and respect that they feel from the other team members and other roles involved in the work, what they do to coordinate behavior and communicate, and what they do to reflect and learn on their processes. And if we have good competencies working within a lot of the good team structures, we get the good stuff. We get high levels of psychological safety, which means I feel okay taking risks in front of other people on the team, and which is very similar to trust. I have something I value, and I can put that in your hands and feel confident you're going to handle it appropriately. And we can be adaptable, and we can be resilient. We can change to a changing world, and we can persist when need be, when things get tough. And that's what really kind of contributes to team effectiveness overall. So there's lots of pieces to this, and they fit in lots of different places what we care about for our implementation science work. I'm imagining most folks are at least somewhat familiar with the CFIR framework, which outlines a lot of the pieces that go into implementation science studies, the things that are going to influence, are going to determine what types of strategies may be more or less effective, and that overall are going to present the kind of environment you have to work within to implement a change and make that happen. So, we have the characteristics of the individuals involved in that change. What are they? Who are they? What are their kind of relational networks? Are they leaders? Are they frontline providers? Composition, all the individual people. There's an inner setting of the kind of micro work environment or the organization itself. How is it structured? What's communication and culture look like? All those types of things. Outer setting to the broader world. Are there incentives to do the thing you're trying to get done or not? Are there financial barriers getting that done through reimbursement practices, whatever you may have? And there's an implementation process, how you go about engaging people and co-creating or not the solution to be implemented. And there's a very, pretty standard logic model for any implementation study, and you can start overlaying those things, the attributes of the team, and how do those play out with kind of our model for change in any kind of implementation study, right? So for individual characteristics, you can be thinking about does my intervention change coordination demands? Does it make it necessary for people to work together more closely or not? And that can be pros and cons depending on what you're doing. Is it changing role structures and responsibilities? Those are frequently things that happen with the interventions we put out there. And they're very important to think through from the team performance side. The inner setting, what is there variability in kind of the team climate or the general levels of psychological safety in the environments we're trying to implement something in? That can be a big determinant, especially psychological safety for adopting new interventions. People need to feel safe trying things out, asking questions. All of those types of things can be a big difference. For the outer setting, does the intervention require people working across more boundaries than they used to outside the organization? And that can be reimbursement practices. We have a big effort now restructuring roles for prior authorization for different things. And that is a huge piece of this, is linking our organization with what's happening on payer sides to make things kind of move more smoothly to get interventions in place. Characteristics of the individuals, there's a lot of variability in the composition of people doing the work that needs to change, or the structure of their task, all those types of things. And then the process, implementation strategies for teams, there's lots of choices here. Team-focused training, structured communication tools, briefings and debriefings, and there's redesigning the kind of team's work too. Is can we deliberately change kind of the roles or the structures, the composition, interdependence of the team members in different ways? And that plays out to the mechanisms, improved team processes or team states, and that can link to lots of different kinds of outcomes, but particularly on the clinician and patient side, patients' perceptions of teamwork on the clinical side is a pretty big indicator of overall patient satisfaction, which is related to lots of other things we care about too. And the overall quality of teamwork on the clinical team side is an important outcome too, because we know that's linked to organizational outcomes like retention or turnover, conversely, and well-being of staff members. So good and important outcomes in their kind of own right. So teams and teamwork are a pretty important part of the implementation process. Each of these are important things to consider. Each of them are also kind of measurement opportunities. How do we know that these things are happening or not? Or how do we know there are differences between sites or facilities or providers implementing different types of things? We can measure those things. And historically, your options have been to measure teamwork. You ask people or you go watch them. So you have them fill out surveys, or you do observational approaches, or you do more qualitative methods. And all of those are still fantastic and still what you should be doing. All these things I'm going to talk about now are really kind of complementary to that. They have the potential advantage that they scale much more easily because they're less labor intensive. They have the downside is that many of them are still very much in development, and we'll see as we go through a lot of these. They're very low-level behavioral things many times, and there's just no replacing just asking someone how they feel about the teams that they're on. That's really informative. These other things are good indicators potentially of what's going on, but they're really to kind of complement at scale what you're learning from the traditional methods, is my kind of personal take on all of this. But in addition to those traditional methods, you have linguistic communication as kind of a big domain of these unobtrusive measures. And by unobtrusive measures, I'm talking about things that you can do without directly watching someone or asking them, right? So you're not requiring a response from the person. You're capturing aspects of the team interaction or the team structure without those methods. So part of that is just the verbal communication we have and the words that we use. Those matter. The communication we do without words also matters quite a bit. Turns out that you can learn quite a bit about how a team is functioning, but by just looking at shared physiology. And I'll talk about an example of this in one of the last example of how mutual influence in physiological measurements can be a decent indicator of what's happening in teams. Certainly there's a lot to learn in that space, and certainly it is not practical many times, but it's a really interesting area of research that has some applications in some spaces for what we do. And the last one is absolutely most practical, is some version of activity tracing, ambient sensing of the things that people are doing. A lot of computer vision applications, but also a lot of really basic things of the administrative data we collect and EHR records and use log data that we don't make full use of. There's a lot of opportunity in that space, and I'll talk about one that we've used in an implementation project that capitalizes on just basic administrative data that we don't make use of enough in these types of studies. So those are the kind of big buckets. There's probably a million other ways to kind of slice and dice this, but in terms of the world of what I'm working on and what I see most people working on, it falls into one of these spaces and increasingly kind of crossing those boundaries and using most of them. But again, this is the linguistic communication and the activity tracking are closest to go use that right now. The other ones have a lot of work to do. But there's been huge research in all these areas, and I won't go through this in tons of detail. I'll get to the kind of examples more. But just to, I'll share these slides after the talk, but there are plenty of examples in the research world of obviously the words we use matter within teams. And some of that's domain-specific content, and there are coding systems that have been used for well over 50 years to categorize all this stuff. The ones in healthcare used for patient-physician communication. There are a number of the ones we use the rotor interaction analysis system quite heavily here, and I'll talk about that a little bit. But then there's some non-domain specific content. So it's not really what we're talking about. It's more stylistic, or it's about things that are emotion words or use of pronouns, which have a lot of social weight to them. There's lots of domain specific. I don't need to talk to you about medical information for us to know something about that interaction. All these other more indirect features matter a lot too. Similarity in word use matters a lot in different contexts and is not always a good thing, but has been shown to be a positive thing in some contexts, and problem solving at a group level, not necessarily a good thing. Just depends. And then some sequence in word use to closed loop communication, and this idea of an anticipation ratio. How much information am I sharing before you ask for it versus how much Do we have to wait for people to ask before they receive information they need? So a lot on that. There's a lot in the paralinguistic communication, just around flow and communication. Like if we're having a more kind of even or egalitarian approach to turn taking, that's a better indicator of teams versus someone dominating it. And in the patient communication world, the whole verbal dominance is a big feature of poor interactions often. Facial expression and gaze behavior, or having shared visual search of different artifacts in our environment in the information space, that matters a lot. Vocal features, more for assessing individual affect, but a huge literature on that as well. And then gesture and posture, also carry information about kind of team interactions sometimes. And the last, I'll go through an example more specifically around the physiological dynamics. There's a review we did, I guess, a number of years ago now, and there's a few others too I should have cited more recently. But there's a really large growing literature on kind of social physiology in team and work and in team groups, in task performing groups and teams. There's been a lot of this literature for decades on counselors and patients, and between parents and children, that this work is kind of built from, but there's a lot there. For our implementation science projects, we're not hooking people up to FNIRs and EEGs or even any of these other things, but I will talk a little bit about kind of what this, how this could be used in some research projects in the last work. And there's a really fascinating literature on this, and a lot of good stuff to come, I think. In the last one, just a few kind of examples. This is, again, what I think is huge opportunities that we don't use that much. So, for example, there's been a lot of research on identifying just who teams are through kind of shared documentation practices, like who's documenting on what patients, to get an understanding of just who is working on a care team. And believe it or not, that's like a fundamental thing about a team, like who is on it. But in a lot of more complex care areas, it's not easy to know exactly who's taking care of this patient in total, right? You might know the physician in charge or the specific bedside nurse for a day, but there's a whole collection of other people caring for this patient, and you don't know who those people are, and it's not easy to find out. But there are measures to understand kind of EHR use logs to just figure out who's on care teams. And some of those measures are great for mapping kind of care processes and patient journeys through the system, and identifying patient risks too. We use location tracking devices. Many healthcare facilities have them inbuilt now. We use those, and some of those patterns of kind of co-location of staff can indicate whether patients are at risk of different types of errors. There's a good study in the nursing world looking at kind of networks of co-location of staff and risks for medication errors and other types of things. So there's a lot that can be learned from some of these basic administrative and activity tracking studies. So first example I'm going to talk about is team familiarity and enhanced recovery. This was a long project. I spent many years of my life working on enhanced recovery after surgery programs, and the idea is there are things about surgical care that we know that patients should receive, and they don't. Right? We've known many of these things for a very long time. Evidence is always changing, but this idea of an enhanced recovery pathway, which is really a structured protocol of all the things that are supposed to happen for a patient, it's really just work organization. But it came out of Europe over 20 years ago, demonstrated to have huge impact. In principle, has been adopted here. Professional societies have bought in on it, all those things, but it doesn't happen in many facilities. So we were implementing a collection of things that involve patient and family engagement, because that's a huge piece of it, for them to understand what these interventions do and why, because some of them are counterintuitive. Staying in bed is not good for you. Getting up and moving as soon after surgery as possible is what's good for you. Pain management is a big fear for people. Opioid sparing regimens are much more effective than high dose opioid plans, and getting people off of those, and even getting healthcare staff to realize that maybe most people will not need opioids. other analgesics will do just fine, and that will allow them to not be as not have issues with vomiting and be able to get out of bed. All these things come together. So there's a lot of things that run counter to people's perceptions of what is good on the patient side and care provider side. But there's a lot of evidence that this is the way to go for most people. So it was a long, many-year project to get this up and running. And this is the broad strokes of what these care pathways look like. We did this in colorectal surgery, gynecological surgery, orthopedic surgery, hips and knee replacements, and in emergency general surgery. There's a lot of things that have to happen preoperatively. If this is a planned elective thing in the surgeon's office, having communication about what the expectations are for pain management, all these things, there's a lot of things that need to happen day of surgery, both on the patient side and for the care team side, administering appropriate prophylaxis and all those things. Intraoperatively, there's a lot of pieces that have to happen post-operatively, and then post-discharge, there's pieces across the entire kind of continuum that have to be coordinated. So it's a huge teamwork and coordination challenge. And teamwork and coordination has been a challenge in healthcare for surgery for a really long time. And I'm going to, for a moment, just carve out the intraoperative piece and not talk about the whole kind of care pathway, because that's where the familiarity piece mattered most directly for us. There's a long history, 20 plus years of team development interventions in the surgical world. Most of these are kind of process interventions or training people to be better communicators, better leaders, or it's structuring really critical kind of team communication pieces, briefings and debriefings, huddles, that kind of thing. Those are all really effective, but they're a challenge to sustain, like any kind of training program. And there's thoughts that a lot of the problems or challenges, there's a, like a not stereotypical, but it's the general prevailing kind of thought is that the climate for teams is tough in surgery, and part of that could be because basically a lot of the anonymity of working together, how schedules work. You may be in large facilities, academic medical centers, particularly. You may be working with totally different people quite regularly. In any one case, working with people you do not know or have not worked with before. And on top of that, you're masked and cannot see them. And in those situations of anonymity, people are much more likely to treat people poorly socially than they are otherwise. So anyway, so there's a thought that, and there's some evidence that changing some of the structural things about these teams can be a huge benefit, because you don't have to keep training people over and over again, or to make those effects long lasting. And there's evidence out there in the literature that this is true. It's across a wide range of outcomes, the familiarity of the team members, how often we work together, how well we know one another, is related to healthcare utilization outcomes, room time, length of stay, patient mortality in some cases, complications and adverse events. But these studies are usually pretty low quality because they're all observational studies. There's a few that are interventional where they implement dedicated teams. But it's messy. It's a messy literature, but it seems like this is really important. And the management literature outside of this kind of agrees that there's a positive benefit to having people work together, at least to some degree. You can overdose on anything, I suppose. So we did an analysis of this in our own health system across 5 different entities, because we wanted to know, one, not just like, does the familiarity of these people working together matter, but like how much? Like how much do you need? Does it got to be for how long? Like, and then 2, for amongst whom, right? Is it everyone on the team that has to really know everyone, or can you get away with a little more flexibility in that? Because operative scheduling is a tough nut to crack. It's difficult to make interventions work, to change surgical scheduling practices. So we used a measure to create an index of kind of shared work experience based on just records from the EHR of who worked on which cases. And I won't get into the details because of time, but I'm happy to kind of chat with anyone about it. but you essentially look at all the cases, all the team members and all the cases that they worked, and you just create an index of how much this team as a whole worked together. And that ranges 0 to 1, or you can correct it a little bit for the maximum number of cases worked by any one person. So we had almost 100,000 cases across our system where we looked at this, over 1,000 surgeons and over 1,000 different types of procedure types. This is a number of models. We looked at familiarity calculated across a 1 month, a 1 quarter, and a 1 year time frame. And we also looked at it calculated for the core team members and the whole team members. The entire team was anyone that had any contact with that patient intraoperatively. The core team was anyone that was in that room for at least 50% of the room time. And we found that in general, core teams are more important than the whole team. And there's some weird things that happen with the whole team, especially on extended room times. We looked at the effect of these prior work history metrics on the likelihood of having an extended room time, which is a room time for that specific procedure type, above the 75th percentile, and same thing with extended length of stay. And more familiarity over longer periods of time helps more. So more matters, but even a little bit helps. Familiarity, even over shorter times, especially for length of stay, kind of mattered. And it really matters for the core team too. And in fact, there's some deleterious effects in this model for higher familiarity amongst the entire team for the room time outcome, which seems a little counterintuitive, but there's definitely literature in the management world suggesting an inverted U for familiarity. You can have too much, and also the difference in familiarity for performance for routine tasks versus kind of novel things. So it's a complicated thing, but the big takeaway is, yeah, it kind of matters especially for the kind of core team members. And that's a finding we used in our enhanced recovery implementation practice. So that core team matters for outcomes. One of our strategies interoperatively when we piloted those interventions at Hopkins before we did the dissemination program was to think about how we're going to roll this out for some of the kind of core people, like the surgeons in our first service line, which is colorectal surgery. There's only 4, so this is a small pilot. So they were all on board. They were for this. The anesthesia department is huge, and you have anesthesiologists and you have CRNAs who also perform cases. So what we did is try to, out of that huge department, form a kind of strategic core for this ERAS team by recruiting people that would be interested in this. So it's a volunteer thing, but you get education, you get feedback, and that we work with the schedulers then to make sure people part of that team ended up on these specific cases as much as possible. And these are terrible diagrams. I apologize. You can't really see it, but the first one is a network of shared cases before the ERAS implementation program. And the second figure is a network of shared cases after. The blue dots are surgeons, the reds are anesthesiologists, and the yellows are CRNAs. And did a network analysis of the whole thing. And the ERAS team, anesthesiologists and CRNAs both became more centralized through different metrics, but they became more centralized in the shared cases they have. So they became more of a smaller pool of people working on these projects, and teams that had this patients who had this ERAS team perform their surgeries had better compliance with protocols and had better kind of outcomes. So thinking about some of those issues, how we can use some of the kind of low-lying data that we can use to understand attributes of the team and use that to kind of engineer some implementation strategies and evaluate our implementation strategies worked out really well for us in this specific case.
Mike, can I interrupt you really quick? There was a
Yeah.
question in the chat before you move on.
Sorry.
I wanted to get to was just asking about you had on that previous slide, and I think you were talking about in this one about core team members versus all team members, and just being clear on what that means. What is a core team member versus just the all team members?
Yeah, that's a great question. And our definition was a practical one due to information constraints. in a perfect world, for these cases, you would go in and define who is core and who is not. And that might change based on the specific procedure that's being done. Again, this was over 1,200 different procedures, and core for a robotic procedure might be very different from core from a, outpatient, less intensive kind of procedure. So we defined it just based on time measures, who's in the room, at least half the case, versus who isn't. That was something that generalized across all those conditions. It is not perfect, but it does identify the group of people who are most involved in that case. So it's an excellent question. Our answer in this study was a practical one, but not a particularly great conceptual one. For this one, is a little better. It was surgeons, anesthesiologists, and CRNAs, anesthesia providers. Yeah. So linguistic analysis. So trying to understand what we can glean from the words people use and what that means for the kind of team interaction. I'll talk about two approaches here. One, and this whole line of work started before the large language models came out, and I think this is still, there are pros and cons to different approaches to linguistic analysis, and I'll talk a little bit about those. But we started some of this work quite a while ago in this, using the idea of style and style matching, to pursue that outside of kind of actual kind of content measures. And they'll also talk about speech profiles for physicians, care providers, not just physicians. So there's huge literature on communication and patient communication and how that relates to kind of care outcomes and people's perceptions of the care and patients' adherence to the agreed upon kind of plan coming out of those interactions. So the first study I'll talk about is from HIV care, and it was an archival study we did. So this was from a time frame when adhering to HIV care regimens was tough, and it was like the nature of the interaction with the physician did play a pretty substantial role. When as a patient I go home, my medication regime is difficult to stick to. Other things can be helpful. If it's an easy thing to stick to, then maybe it's not. This isn't important. But it very much was at that point in time. Thankfully, the burden on people is less than it used to be, but certainly not great. So across all that literature, good findings that, the quality of the interaction is linked to, as I said, adherence, but then also in HIV world, viral load suppression, which is a kind of important indicator of how well a disease is being managed. A lot of this has focused on communication content. As I mentioned before, there's a lot of, and it still happens, and it's still really important. I don't see it being replaced by LLMs anytime soon necessarily. Kind of human coding and human analysis of transcripts, and there are lots of coding schemes to do that. We thought, hey, wouldn't it be nice? There's this idea in the social psychology and organizational world of just style and language style, and the degree that we match or our styles converge over time is a positive indicator of something about that interaction. And what's nice about that is it doesn't require human coding, and it's also generalizable across lots of different kind of care settings. So it doesn't really matter what you're talking about. It's really the style that you're talking about that matters. And there's a paper, this first study is published earlier this year down at the bottom, but it's where we were looking at, this is one very specific definition of style, which is defined as basically shared commonalities in the use of what's called function words. And these are those lists of words there. And what's unique about these words is they proportionally are a lot of our communication, and they don't necessarily carry a ton of meaning on their own. There are many ways to express the same ideas with varying levels or distributions of these types of words. So it really is how you're choosing to express yourself very much more than the actual kind of words or ideas you're trying to communicate. And there's a method to go through. If you're not familiar with it, it's been around forever. It's a closed kind of vocabulary linguistic analysis approach called Luke, which uses dictionaries to categorize a proportion of words in these different categories and many, many other categories. And you can create measures of the degree to which our styles are similar across the set of transcripts. You can do that in lots of different ways, and we explored all of them. So you can look at the entire conversation, that first path down the side. You take a transcript and you condense all the speaker's speech into one chunk, and then you analyze that chunk, and then you look at the whole interaction level, what degree did our style match. And then there's different versions of, well, you can do that same thing on a turn-by-turn basis, and not just, and if you do that, in principle, it lets you look at not just the degree of matching, but who is matching whom. Am I matching you? Or are you matching me? Or are we following each other? And we did that. That's a well-documented approach in the literature. And we also did a version, given the nature of these conversations, doing that. There's lots of shifts in patient encounters of who's talking. Up front, it's very much patients talking, care providers saying very, very little in between the different utterances. And at the end, it's the opposite usually. So trying to smooth that out with a rolling window and look at an indicator of how our style is changing throughout these interactions was another thing we kind of looked at. And then you can have an overall indicator of how much do I, as a patient, match my clinician, or does my clinician match me? And then the last thing we did was look at trajectories throughout the interaction. So we did that turn-by-turn analysis, chunked it up, and then we did an exploratory kind of growth mixture modeling, which basically looks for differences in trajectories of communication patterns, in this case, communication patterns, and look for differences in outcomes there. So I'm running short on time, but in the article is there, but this is archival data. We had the transcripts, which we did that analysis on. We had RIAS coding, which talks about, we looked at only a few different measures from this, that's human coded data from the interaction, which is the verbal dominance, which is, again, that's a pretty negative indicator. If your care provider is just talking much, much more than you are, that's generally viewed as a negative thing. And also patient-centeredness, which is a combination of kind of social talk and chit-chat and things like that. And then we looked at those things relative to patient perceptions of speech similarity. So that was kind of our outcome. Is there an indicator that these the matching measures line up with patients' perceptions of how similar they're speaking? And then we also looked at some current validity with the RIAS kind of findings. So this is the distribution of the main variables. Conversational, if you look conversationally, there's a lot of range restriction. Well, in all of these, but everything's topped out. It ranges from 0 to 1 in terms of how much you're matching. With 1 is we're totally matching. There's really kind of a high skew to that. The other measures just shifted down, but the distribution is not too much. But when we looked within conversations, what we found is there's really kind of two groups for change within a conversation. There's a group of people that match from the beginning and they stay high. So there's people that just talk like physicians, or physicians talk like them throughout the entire conversation. There are people that start low, but everyone tends to kind of gravitate towards a more aligned style, which is also a documented thing. This just happens when we engage in conversations with people. We start to sound more like them. So there's two big groups: people that started off the same, and then people kind of that got the same. And then when we looked at the relationship between those features and patient perceptions of similarity and those two RIAS measures, we found some interesting things. At the conversational level, the verbal dominance aligned. So when there was more conversational matching, there was less verbal dominance, but nothing else. For the turn-by-turn matching, there were more significant findings, but in the opposite of hypothesized directions. Like some funky things are going on with style and these more nuanced measures of how that style is changing over time. We have replicated that in 2 other data sets now, and it's consistent in this general internal medicine, primary care visits across a couple of settings, the same thing kind of happens, which is weird. But it's a signal of something that's going on in the interaction. And for those accommodation classes, compared to the unchanging, the people that started high and stayed high, the increasing group had higher perceptions of similarity, lower verbal dominance, and higher patient-centeredness from the RIAS coding data. So there is a signal there. It's a complex one, and a lot needs to get sorted out. But there's something going on there. I'm running quite late, I think. So I'm going to skip the speech profile stuff if that's okay. I overbuilt my slide deck here. I'm going to jump to the last one because it's the physiology piece. So there's at least some discussion of these different kind of modalities. But the speech profile one was I'm happy to share a paper when it's almost done. I'm happy to share that one. So this one comes from a study we did in a pediatric intensive care unit here on this idea of collective allostatic load, which is really about how resilient our teams can be and how they respond, excuse me, to kind of chronic and acute team stressors. And we're doing this to have, this also connects with a challenge in healthcare delivery on ICU unit strain, right? That's not really predictable how many ICU patients you're going to have at any point in time, and you've really got fixed resources. So it's tough to figure out how you kind of adapt and deal with that as demand kind of changes, and what do you do with that. So we're hoping to understand some of the kind of internal dynamics of what happens in a unit under different kind of chronic and acute stressful situations to help inform better management systems for that. This is a picture of the ICU, or not a picture, it's a diagram of the ICU. The patient rooms are all around the outside, the grayed out areas, and other unit. The big blue areas, the main entrance. Around the other side of the corridor are nursing stations, conference rooms, medication rooms, supply rooms, stuff like that. What we did is we recruited teams of physicians and nurses managing care. This 4-person team, so it's not the whole unit, it's a 40-bed unit. We couldn't instrument everyone, but we instrumented a small number of people and collected data from them daily. They came in, they put on some sensor sets, which I'll talk about, and then they filled out surveys throughout the day in terms of their workload, their perceptions of teamwork and trust, and kind of burnout at the end of the day. And we also collected administrative data from the patient care. We use an activity tracking badge, the motion tracking badge on the far left. That's an inbuilt system in the hospital. It can give you where they are, rooms. It's good for figuring out where they are in rooms. It breaks down a little bit in hallways and whatnot, but it's okay for knowing where they are in patient rooms. Had some physiological data, cardiac and electrodermal data. We tried for these communication sensor badges. We tried everything that was out there. None of them work very well, right? So we were hoping to have, and that was supposed to be able to capture some of the paralinguistic communication, vocal features and vocal stress analysis, but none of those actually were very good. And then we did the multiple surveys through kind of smartphone. There's a really interesting paper on how to do this. I'm going to talk just about the physiology data from this piece, from this study right now, and how we're analyzing this is we have data from 4 people. These roles are different. They're from a NASA project, but you have a nurse and you have 3 fellows working the day. And what you have is a correlation matrix, but it's kind of in a time-lagged correlation, cross-correlation of the time series of different people's physiology, right? So you get from that first role, it says commander, but I think it says charge nurse. So the charge nurse to the blue fellow, you get how much my physiology predicts your physiology kind of in the future over different time frames. And that is an indicator of influence. And you get the opposite too. So you get for each person dyadically on the team, each group of people dyadically on the team, you get a sense of mutual influence. How much am I influencing your physiology and how much are you influencing mine? And you can also get an overall level for the whole team. What we did with this, or one of the things we did with this, is look at this from a profile analysis perspective. So this is like the trajectories, this is a mixture modeling approach. So we're looking for subgroups of people that share patterns across multiple indicators. And that's kind of where a lot of this unobtrusive stuff is, because there's a lot of data, and how do you reduce it in a way that kind of makes sense? And mixture modeling is one approach that kind of makes sense for a lot of this. So basically, we're looking at both the empath score, so how much are other people influencing my physiology, and the driver score, how much am I influencing other people's physiology across different metric sets. And we're looking at that within shifts, within days. We have 100 shifts from about 30 different people, looking at patterns across those empath and driver scores for cardiac measures, and EDA tonic and phasic scores, to see other different differences in patterns. And long story short is, yes, there's some reliable, good, consistent patterns that you can find at the day, for a day. So this is at each day. Profile 1 there is basically pretty flat affect. Like, I'm not influenced, and I'm not really influencing anyone. And one thing you'll see is empath and driver scores they track together like completely. In the other literature, they differentiate, but those are all lab studies in the field. It's just a measure of affective reactivity, basically. The empath and driver scores don't differentiate all that well, unfortunately. So you have 1 flat affect, 2 moderately low affect across cardiac and the phasic scores, whereas the tonic scores are really detached, right? So and the tonic scores are kind of a slower acting piece of sympathetic nervous system activation. And then you've got the last 2 profiles, which are really high tonic score synchronization within the team. And then the last one is really high cardiac and phasic synchronization with the team. The last thing you can do is, okay, those are score profiles within a day. Those cluster within individuals, and they're people that exhibit different patterns. And the big difference here, this is not entirely clean, but the big difference is there are people in this sample, 9 out of 30 plus, who are much more likely to have that profile 1, which is completely flat affect. Profile 2, which is the really low tonic profile. And these profiles matter for people's perceptions of teamwork and for their well-being and kind of burnout. So people who are in class 1, which are people who are more likely to have that profile 2, which is really low EDA tonic, in general are much more likely to have collective competency with the belief process and potency. Those are aspects of kind of team vitality, collective efficacy. They're much more likely to have higher perceptions of the quality of team interaction. And they're much less likely to report being burned out at the shift. So there's signal here about team interaction that has relationships to people's perceptions of teamwork and other kind of outcomes we care about. And also there's a lot of relationships to traits that we know influence teamwork too. And I apologize, I'm way over. I overbuilt my slide deck. I'm sorry about that. I didn't see any. I'm happy to ask any questions or chat with anyone offline too, if any of this is remotely interesting.
Thank you, Dr. Rosen. So we do have about 4 minutes, and it looks like we have a few comments, looks like Heidi has another comment in the chat. So feel free to unmute or send your questions in the chat, and I'll pass it over to you.
Thanks. So I'm trying to understand the question. Dynamics change within days within groups of the same people. I don't have any data like dynamics in terms of the measures we have. I don't necessarily have any data that kind of shows that. But I think that is definitely true. Team processes kind of vary within even intact teams kind of over time. The challenge, we have a lot of data, our PICU study and even the surgery study, people are shuffled around kind of a lot. So it's tough to find the exact team working together more than once. That's not how we're organized, unfortunately.
Yeah, I was just struck by how many different variables contribute, like there's just like level on level of complexity, right? There's like how familiar the people are with one another, and then there's the way that these various like the stressors and the way different people respond to the stressors.
Yeah.
It's like incredible thing to trying to tease these things out.
Yeah, and I mean, I think in the like compulsion with in our age is that there's data to capture all of those things, and you can then model all of them. And maybe we're kind of getting to, we're going to do a lot of it, but the more practical thing is what are the things that what are the kind of opportunity or leverage points across those things? Are there simple solutions to tough problems? And sometimes there are, but they're really tough to find. I don't know. That's a great question, though.
This is really interesting work. Thank you for sharing. I'm curious,
Sure.
it sounds like most of your work's kind of been within healthcare systems and within hospitals. I'm curious about like how well you think some of these methods would translate to other settings where maybe there's less kind of like top-down investment in teamwork or just different structures of teams.
Yeah. So in addition to healthcare, I did a little bit of research work with NASA, and we do a little research work with the Department of Defense, because those historically are the places that care about teamwork. Healthcare has not been the place that cares about teamwork until much more recently, and the caring about it has been much more like superficial and divorced from investments and improvement strategies, in my experience. So I think those apply in those places. Definitely, because that's where a lot of this research came from, and I'm just taking what other smart people have done and trying to do it in healthcare. But yeah, I mean, I think a lot of the knowledge we draw on in the team world comes from the management world, which more of it increasingly is coming from healthcare, but a lot of it historically has not. And a lot of it is pretty close to spot on. Like the things that matter in organizations are the things that matter in organizations, whether you're taking care of patients or doing other things at a high level, right? So I think we can definitely learn a lot from everyone else that's interested in this. But as you said, I think the top-down investment, like that's critical. If you want to make a difference, you have to have people willing to do something about it. You have to have leadership, and leadership that can find resources, and that's often what we're missing.
Yeah, absolutely. I was thinking about just from the research perspective too, like being in the same healthcare systems, you have things like ID badges and sensors and that sort of thing. And thinking about like other contexts. So I'm doing a lot of work with like child abuse teams. And so they're like people from different organizations and different systems.
Yeah.
So there's not that same like one system that is invested in improving teamwork in these teams.
That's a huge challenge. Yeah, absolutely. It's a great point.
Okay, we are at time, but I just want to say thank you so much, Dr. Rosen, for your presentation. We will be posting the recording of your presentation on our website, so just be on the lookout for that. And then also, if you have a chance, please take our 1-minute evaluation survey and let us know how we did. Have a great day, guys. We'll see you in December. Bye.
Thanks, Mike. Appreciate it.